I'm Dr. CHINYERE.A, a 2007 graduate of American International School of Medicine with 10 years of clinical experience working as a certified nurse at various hospitals, long-term acute care facilities, nursing homes, with patients in their private homes, from doing my clinical rotations here in the United States, from 2 graduate medical education programs, Henry Ford Internal Medicine Residency Program, Detroit, Michigan, Springfield Family Medicine Residency Program, Springfield, Illinois, and from various observerships, from St. Elizabeth Family Medicine Residency Program, working with Dr. Zahidi, and from Huntsville Family Medicine Residency Program, Huntsville, Alabama, and from Harris Fort Worth Hospital, Fort Worth, Texas. You're working with Dr. Unini, and a master's in business administration from Davenport University, Grand Rapids, Michigan, and some research experience from University of Texas Southwestern Psychiatry Department. I'm working with Dr. Carol North and Jenna Downs, who are both awesome people, and currently involved in preventive care and going through the March 2014, and also in education and counseling of victims of depression and sexual abuse, which I haven't experienced personally, but motivated by patients I've seen in my practice. And I would like to welcome you to Dr. Chiquito Mentoring Preventive Ustream show, where we are always I'm learning about new topics every day. This show is designed for healthcare workers, and also for non-healthcare workers to be able to to enlighten them about various healthcare topics that we see every day in our hospitals, on rounds, in our clinics, and even as as patients, and also in our families too. And then the process are actually accompanied by powerball questions, and correct answers will be rewarded with prizes. So I apologize for not broadcasting for the 2 previous days. We had some connection problems, and I want to thank everyone for their patience. So it's 7:47 currently, and I'm just gonna post on my social media that we are about to start. I want to apologize once again about I'm starting late. The show normally starts by 7:30, and we're gonna try to keep it like that. Today we had some connection issues, and that's why we had to start by 7:45. So I'll just post on my social media that I'm broadcasting live on obesity and weight measurement, which are very, very important topics. So today we will talk about obesity and weight measurements. I'm just gonna turn off my Wi-Fi here so we can be able to learn about obesity and weight measurements. So I'm getting my slides which was shared on my website, and you can be able to I'm look at it on my website, and be able to read it as we go through the show, and be prepared for the quiz and the powerball questions. So obesity and weight measurements. I am gonna start with a case study, which is designed to, help us to be able to understand the topic. And it's in the office, and the presenting complaint, you have a 22-year-old woman who presents with hirsutism. Her vital signs: pulse is 80 per minute, blood pressure is 122/82 mm mercury, temperature is 98.7. Her respiratory rate is 16 breaths per minute. Her height is 162.5 cm. Her weight is 90 kilogram. That's 198 pounds. And her then to the history of present illness. A 20-year-old obese white female comes to the physician's office with the complaint of male pattern body hair. She states that besides facial hair, hair is also present on her chest and in the lower abdomen. Her other complaints are amenorrhea for the last 4 months and obesity. She states that her menses have always been irregular since her first menses at the age of 14 years. She neither smokes nor drinks alcohol. She is not using any prescribed or recreational drugs. She has never been sexually active. She denies any other complaints. She is allergic to penicillin. Family history: father is healthy. Mother has a history of diabetes mellitus. She does not use any recreational drugs. She is unmarried. Review of system are unremarkable. So I'm sure at this point, this 20-year-old female who presents with complaints of obesity, facial hair, amenorrhea, at this point you might have some few differentials on your mind. You might think that it could be depression. I mean, she's 20, she could have some things going on in her life, and and having depression. Or it could just be obesity. It could be polycystic ovarian syndrome. It could be Turner syndrome. It could also be bulimia nervosa. So all these are actually differentials, and then also it could also be type 2 diabetes mellitus. It could also be just ordinary hirsutism, and then also it could be hypothyroidism. So all of these are differentials that you have to think about as you go along in trying to find out exactly what the problem is. So I'm just going to continue to the topic for today, which is obesity. So going to the next slide. Obesity is common, serious, and costly. In 2009 to 2010, more than 1/3 of U.S. adults, which is 37.5%, were obese. So that's actually a very, very high number. That's a very large number of the population, and that's why it's very, very important for primary care physicians, for individuals to know about this topic, obesity. And that's why we are talking about it here on Dr. Chiquito Mentoring Preventive Ustream show. So then the next point about obesity is that overweight and obesity are both labels for ranges of weight that are greater than is generally considered healthy for a given height. So if you go to your physician, and your doctor says that you're overweight or that you're obese, that's actually means that that's different from normal. That's actually not healthy, and that has to be fixed, to be able to create a healthy population. So for adults, overweight and obesity are determined by using weight and height to calculate the number called the body mass index. So the body mass index, or the BMI, we will talk about that extensively later on. And normally if you go to your primary care physician, normally you get your height and your weight measured. So and then with that they calculate your BMI and tell you what state of health you are in. Now there are other methods too of estimating obesity apart from BMI. Body fat and body fat distribution can be estimated by skin fold thickness, waist circumference, waist to hip ratio, and also techniques like ultrasound, computed tomography, and magnetic resonance imaging. So if you go to your physician and she or he wants to really know how healthy or how obese you are or how overweight you are, then they will probably do skin fold thickness. They could also do a waist circumference or calculation of hip of waist to hip ratio, and also an ultrasound, a computed tomography scan, and also a magnetic resonance imaging. So all of this can be done to be able to find out exactly how obese or overweight that you are. So now BMI is just one indicator of potential health risk associated with being overweight or obese. For assessing someone's likelihood of developing overweight or obesity related diseases, the National Heart, Lung and Blood Institute guidelines recommend looking at two other predictors: the individual's waist circumference, because abdominal fat is a predictor of risk for obesity related diseases. The other risk factors the individual has for diseases and conditions associated with obesity, for example, high blood pressure or physical inactivity. So apart from the BMI, the waist circumference, like we talked talked about a few minutes ago, and then also if you have high blood pressure, if you are not physically active, if you have diabetes, if you have hyperlipidemia, all of these put you at risk for having a cardiovascular event, or make you unhealthy. So BMI is a number calculated from a person's weight and height. BMI provides a fairly reliable indicator of body fatness for most people, and to screen for weight categories that may lead to health problems. So that's how we know if we are healthy, if we need to be able to adjust our lifestyle, our diet, or take some medical, or go through pharmacotherapy. So BMI does not measure body fat directly, but research has shown that BMI correlates to direct measures of body fat, such as underwater weighing and dual energy X-ray absorptiometry, DXA. And then also BMI can be considered an alternative for direct measures of body fat. So BMI is actually a good indicator of knowing of knowing your body fat. Now, however, BMI is not a diagnostic tool. For example, a person might have a high BMI. However, to determine if excess weight is a health risk, a healthcare provider would need to perform further assessment. So, just the BMI itself is not just a way of saying that you're unhealthy. There are other tests that have to be done. Some laboratory tests, some imaging tests that have to be done to be able to determine your state of health. So I talked about BMI extensively, and I'm sure by now you must be curious about what numbers are healthy or not. Well, if your BMI is less than 18.5, that's actually underweight. That means that you could be suffering from anorexia or malnutrition, or be depressed, or so you need to discuss with your physician, and actually see a nutritionist, and also change your nutrition and your lifestyle too. Now, if your BMI is 18.5 to 24.9, then that's normal. That means that you're healthy, or you are actually not at risk for any cardiovascular event. Now, if your BMI is 25 to 29.9, that actually falls within the overweight range, and that's what we say, overweight and obese are bad, are not healthy. Now, if it's 30 or higher, then that makes you obese, and that's so we get worried if you're overweight and if you're obese. So those are the two categories that we have to be able to talk to you about, and figure out something to be able to help you with your lifestyle and your nutrition status. Now, these assessments that we mentioned, apart from the BMI, could include skin fold thickness measurements, evaluations of diet, physical activity, family history, and other appropriate health screenings. BMI can be considered an alternative for direct measures of body fat. That's actually from the Center for Disease Control and Prevention. So we talked about it. You go to your physician, they will measure your skin fold thickness measurements. It's very, very important to have annual physical, so that they can be able to determine your state of health. So they have to evaluate your diet. That's a question that they will ask. They have to evaluate your physical activity. It's recommended 3 days a week, 30 minutes of brisk walking. Your family history, do you have any history of cardiovascular events, or diabetes or hyperlipidemia? And then also some blood tests, some imaging if needed. So now waist circumference, we talked about that, and also the waist to hip circumference ratio. So so that's another way to measure your waist size, and also to measure your weight too. So another way to assess your weight is to measure your waist size. Your waistline may be telling you that you have a higher risk of developing obesity related conditions if you're a man whose waist circumference is more than 40, and then if you're a non-pregnant woman whose waist circumference is is more than 35 inches. So excessive abdominal fat is serious because it places you at greater risk for developing obesity related conditions such as type 2 diabetes, high blood cholesterol, high triglycerides, high blood pressure, and coronary artery disease. So the individuals who have excessive abdominal fat should consult with their physicians or other healthcare providers to develop a plan for losing weight. So if your waist circumference is more than 40 and you're a man, then that's not healthy, and you have to that puts you at risk for obesity related conditions like like high blood cholesterol, like hypertension, like diabetes. And if you're a woman who is not pregnant and your waist circumference is more than 35, then that also puts you at risk for these diseases, and you have to discuss with your physician to be able to determine how to lose weight and become healthy. We're going to go to calculation of body mass index. That's something that that your physician will calculate, and when you go to visit him, and that's also something that we actually should be able to calculate ourselves too. I'm putting up my slide here. But first of all, we have to talk about measurement units. How is weight and how is height measured? There are different ways of of measuring weight and height. So for height, it's measured in meters squared. For weight, it's measured in kilograms or grams, and then height is in meters squared or cm. So now to calculate body mass index, you have to divide the weight in kilograms by the height in meters squared. But then normally, in your physician's office, you might have your height measured in cm. So to now convert it to meters squared, you have to divide by 100. So let's say that we have a patient who comes into the office, and her weight is 68 kilogram, her height is 165 cm. So we have to convert to meters. Kilogram, that's okay, that's the weight. Now the height is 165 cm. So converting to meters, that's 1.65 meters. And then to calculate BMI, we talked about it earlier, it's weight over height. So her weight is 68 and her height is 1.65. So if you divide that, you will get 24.98. So she's a little bit overweight, because like we said, 15 to 24.5 is actually 18 to 24.5 is actually healthy. So now we know how to calculate the BMI, and you can be able to do it yourself. There are also some electronic tools to be able to calculate your BMI. You can be able to go online or go to some websites, and you'll be able to calculate your BMI. Like we said, if your BMI is less than 18.5, that's underweight. If your BMI is 18.5 to 24.9, that's normal. Then if your BMI is 25 to 29.9, then that's actually overweight. And then if your BMI is 30 or higher, then that's obese. So this lady, her BMI was 24.96, and and normal is 18.5 to 24.9. So she is actually a little bit overweight, and she has to talk about losing weight and also adjusting her lifestyle. So now how do we measure weight? I'm sure that's something that you want to know. How do you know what your weight is? Well, have to have your scale, which could be manual or digital, and then also the patient also too. So those are the two things that are needed to measure your weight: your scale, and then also the patient too. So the steps in measuring weight, you have to calibrate the scale and make sure that the dial is on 0. So that means that you have to reset the scale, because that way you can be able to get an accurate measurement. If it's on 0, then that way you will not make any mistakes in the in the weight. And then also you have to wash your hands. And normally you have to wash your hands for 20 seconds. A good way of doing it is singing happy birthday. That's like almost 20 seconds. And then after that you have to ask the patient to stand on the scale with both feet evenly spaced apart. That's very important to be able to balance the weight very well. And then so I have a picture of me I'm stepping on the scale. That's on the next slide. And then after that you record the weight. So that's actually how you measure weight. And then after that you measure the height, and we'll talk about that sometime next week. And then with that you calculate the BMI. So we've talked about BMI and ways of measuring measuring your body fat. And I want to thank the Center for Disease Control and Prevention for the article which was retrieved from their website about BMI for children and teens. And I want to encourage you to check that article out. It's very enlightening. So we have the Powerball question, and it's you're sure at winning a prize. And if you answer the questions correctly and send it to my email or post on my social media, you can be able to get a prize. We have lots of interesting prizes from our sponsors. We have everything ranging from mouse pads to pens, to other technical equipment too. So you can be able to win one of those prizes from our sponsors. And then just send it to my email or put it on my social media, and I'll be able to acknowledge it and then also tell you if you got the answer right. So the Powerball question is the risk of cardiovascular disease increases progressively above 115/75, true or false? So the answer has to be true or false. And we talked about hypertension, diabetes, hyperlipidemia, being ways of determining if you're healthy or not. So that's something that you can be able to integrate into answering your Powerball question. And also the slides are also on my website, and I'll also try to share it on my social media so that it's to help you to have the materials needed. And then the next topic is pertussis. We were supposed to talk about it on Tuesday, but I apologize that we had some connection problems. After today, we'll be here 7:30 every day. I'm discussing a preventive health topic, and getting everybody to understand about these preventive health topics that are very, very common in the community, in the clinics, in the hospital, and even case demonstrations. And that way we can be able to have fun while learning, and also be able to prevent these medical conditions. So pertussis, I have the information on my website. You can be able to just look at it and go with me. So I have a case study. So location is it's an emergency room. Vital signs: temperature is 38.0, Respiration is 30 per minute. Blood pressure is 101/68. Heart rate is 90 per minute. So history of present illness. The patient is a 16-month male who is accompanied by his mother, who provides the history. The patient began to get ill 2 days prior to coming to the emergency room with a runny nose and mild cough. The mother reports that she thought that he had a low-grade fever because he felt subjectively hot. However, she did not take his temperature. The patient has continued with his regular activities and is eating, drinking, and urinating as usual. However, on the evening of presentation, the patient began to have a more severe, harsh, barking-like cough that has increased in severity over the past 10 hours. The patient has become increasingly hoarse and has, according to mother, noisy breathing. Now, then review of system is negative except for some complaints of sore throats, although it's difficult to determine because of the patient's age. Mother denies the patient getting into any small object which he may have ingested. So at this point, I'm sure you must have some differentials on your mind. I mean, it could be, common cold. It could be a viral respiratory tract infection. It could be pneumonia. It could be pertussis. It could be croup. It could also be, epiglottitis. So, these are some things that, you might have in mind as differentials. And then, I have a chart here that talks about the pertussis cases that was reported in Texas between 1920 to 2012. So, and there's a spike, and the cases actually increased, but then it decreased later on. And, I will see why that is the case. And also, there was some epidemic some time ago too, I'm, sure that you heard about it, on the news. So I'm going to the next slide. Definition, what is pertussis? Well, it's also known as whooping cough. So if you hear whooping cough, then that's pertussis, and it's a highly contagious respiratory disease. So it's called whooping cough, is contagious. That's what we need to know, know about pertussis. Now, how common is pertussis? Well, worldwide there are 30 to 50 million cases of pertussis and about 300 deaths per year. So in terms of morbidity, it's 30 to 50 million cases, and then also in terms of mortality, it's 300,000 deaths per year. These are some recent data. But more data is also being gathered. So if your child has pertussis, please don't hesitate to inform me so I can be able to help in collecting and also reporting the data. Then causes. What causes pertussis? Well, it's caused by the bacterium Bordetella pertussis. So it's caused by a bacteria called Bordetella pertussis. That's the causative agent. Symptoms. What symptoms do you have if you have pertussis? Well, coughing. That's the major symptom that people with pertussis experience. And they are coughing fits. So they are prolonged and continued coughing, and it can also last for up to 10 weeks or more. Sometimes known as the 100-day cough. If you have pertussis, most times it can last for almost 10 weeks, and it's also called a 100-day cough. So if you hear that as a descriptive term, that's pertussis. And then also feelings of suffocation or strangulation from the intensive coughing, and also headaches too. So all of these symptoms actually occur mostly because of the coughing fits. So that's what we have to consider as in treatments. So phases, there are different phases of pertussis. There is the catarrhal phases, and it's actually has all the symptoms of an upper respiratory tract infection. So you have sneezing, you have runny nose, and then also and also nasal congestion. So in this phase, the catarrhal phase, the phase 1, pertussis is actually most infectious in this phase. and but then it could also remain contagious for 3 or more weeks after the onset of the cough. So if a patient has pertussis within the stage 1, that's when they can be able to transmit it to others, and that's why it's important, if your kid has pertussis, to be able to inform the daycare, and also to daycare on the school, and also to keep your kid at home to avoid to avoid spreading it or infecting others. And then also the stage 2 is the paroxysmal phase, and that's actually when the patient now has the intense coughing, and also in older infants and toddlers, after coughing they'll have like a loud whoop as the air goes through a partially closed airway. Now infants who are younger than 6 months do not have that characteristic whoop, but they could have apneic episodes and at risk for exhaustion. So that's why you have to watch them very, very carefully, because if they are less than 6 months, they could be able to become apneic and and possibly die. And then also patients also have pertussis vomiting and turning red with coughing, so that's due to the feeling of suffocation, and also the intense coughing also leads to vomiting due to triggers of the reflex system. So the stage 3 is called the convalescence phase. So patients in the third convalescent stage have a chronic cough which may last for weeks. So it's the 100-day cough or the 10-week cough. So in the third stage, the cough could actually become prolonged and last for weeks. So how do we treat pertussis? I'm pretty sure that's what you want to know. I mean, these symptoms seem pretty scary to the patients. And also to the parents too. I mean, if your child has pertussis, you're scared that they are uncomfortable, or they could possibly die. So that's something that you have to know how to treat it, and also to understand the symptoms, and also ask for help by going to the emergency room. So treatments, well, it's mostly supportive therapy. So make sure that they are kept hydrated, water, some cool mist, some nebulizer if needed. But then the main treatment is actually antibiotics, and that's actually used to control the symptoms and also to prevent infection. So what antibiotic do we need? Well, it's erythromycin. That's the main antibiotic. It's a macrolide. And how much do we give? Well, for mild to moderate infection, you give 250 to 500 milligram. That's the base, the estonic, and the stearate forms. Or 400 to 800 milligrams. That's the ethyl succinate form. That's orally every 6 hours for adults. Then for severe infection, you give 1 to 4 grams per day intravenously in divided doses every 6 hours, or by continuous infusion. So if they cannot take oral pills, then you have to give them 1 to 4 grams per day intravenously every 6 hours continuously. Now for kids, how much do you give on kids? So the usual pediatric dose for pertussis is 40 to 50 milligram per kg per day, and this is divided orally every 6 hours for 14 days, and that's the maximum dose. So 40 to 50 milligram per kg per day, and then also 2 grams per day, which is actually not the preferred agent for infants less than 1 month of age. So if they are less than 1 month of age, you actually don't want to give them up to 2 grams. That's gonna be a bit too much. So what forms does this medication come in? That's what forms of erythromycin are available. Well, you have the tablets, 400 milligram. You have the oral suspension, and then also you have the 200 milligram per 5 ml oral suspension, and the 400 milligram per 5 ml oral suspension. So that's how they come. So I have a picture of the 400 milligram tablets. That's the ethyl succinate form. So that's how it looks like. That's how your pharmacist will give it to you, and also explain how it works, and also the side effects. And that's how it looks like. Just to let you know how it it looks. And then also the EES 400. So you know, you have a picture on the next slide. That's how the 400 milligram tablet looks. So that's how it looks, you know, if you go to get it from the pharmacy. And then the suspensions, the EAS granules, 200 milligram per 5 ml suspension, which is actually reconstituted, you know, mixed up a little bit, you know, by the pharmacies. So that's, you know, what it looks like right here, the EAS granules. And then also the erythroped, 200. That's 200 milligram per 5 ml suspension, which is also mixed, you know, up up a little bit. That's, you know, how it looks. And then the erythroped 200 actually comes in two forms. So it comes in two colors. I'm sorry, this is actually the erythroped 400, you know, and per 5 ml suspension, and then the erythroped 200 per 5 ml suspension, you know, comes in a purple form. So that's how you know that that's a medication for children and infants. So what are the adverse effects of this medication? You know, what do you expect? Well, you have abdominal pain in 8% of patients. You have headache in 8% of patients. You have nausea in 8% of patients. You also have diarrhea in 7% of patients. You also have a rash in 3% of patients, and then also vomiting too in 3% of patients. So those are actually the side effects: abdominal pain, headache, nausea, diarrhea, rash, and vomiting. And that's, you know, what you have to watch out for. But then if you notice the percentage of the population is actually you know, very, very low. So you know, you know, may not be able to experience that side effect, you know, but then if you do, you know, you have to inform your physician and let him know, you know, so you can be able to change the antibiotic or, you know, treat your symptoms. Now, what pregnancy category is it? I mean, if you are pregnant, you know, do you take this medication? Well, I'm a pregnancy category B. So that means that you actually can be able to take it if you're pregnant. And then if you're breastfeeding, lactation, well, it's actually distributed in breast milk. And so you have to be very cautious, well, you know, when using it. And the American Association of Pediatrics, you know, categorizes it as compatible with breastfeeding. So if you're breastfeeding, you can actually be able to use this medication, even though you have to be very cautious because it's actually excreted in your breast milk. And then also, how does it work? You know, what's the mechanism of action? Well, it inhibits bacterial growth, possibly by blocking dissociation of peptidyl tRNA from ribosomes, causing RNA. So that's causing dependent protein synthesis to arrest. So that's the mechanism of action. That's how it works. How is it eliminated? Eliminated. The half-life elimination is 1.4 per hour, and then the excretion is mostly you know, through the feces and also through the urine too. And you have 2 to 15% as unchanged drug. So that's the excretion mostly through the feces and through the urine, and you have 2 to 15%, which are actually not changed, you know, or converted. So now, apart from you know, erythromycin, you know, what other medications do you use to treat pertussis? Well, azithromycin, you know, known as Zithromax or Zmax, then clarithromycin, known as Biaxin, and then trimethoprim sulfur metaxazole, known as Bactrim DS or Cetra DS. So those are the substitutes for erythromycin. Now, how do we prevent this disease? I mean, you know, it can be treated, in the hospitals by physicians, by a healthcare provider. You know, I mean, if your child has it, he can be able to recover on pharmacotherapy. You know, but then you know, you actually want to prevent it. You know, because our aim is to create a healthy population to decrease the number of sick people. So prevention is through vaccination with DTaP for infants and children, and with Tdap for preteens, teens and adults. So for infants and children, you use DTaP, and then for preteens, teens and adults, you use the Tdap, which are two different forms. One is acellular and one is cellular. And then for exposed individuals, let's say that your kid has it and you're an adult, do you get scared of catching it from your kids? Well, you actually have to go on prophylaxis. So you actually have to take erythromycin 50 milligram per kg per day, divided 4 times daily for 14 days. And then an alternative regimen is clarithromycin 7.5 milligram per kg twice daily for 14 days. So that's the duration of treatment. Erythromycin or clarithromycin, that's Biaxine 7.5 milligram per kg twice daily. So I want to thank the Center for Disease Control and Prevention for this awesome article, whooping cough or pertussis. And I encourage everyone to check it out and read it. It's very, very informative. And I have a quiz. This quiz is actually designed to be able to help us to understand the topic, to go back and be able to get the content of the presentation. So I'm encouraging you to be able to post your answers on my Facebook wall. I don't see anyone who has posted an answer yet, or who has posted a comment. But if you post a comment, I can assure you that I will be able to respond to the comments and answer any questions that you may have. So the first quiz is: vaccination of preteens, teens and adults, including pregnant women, with Tdap is optional for families with new infants. So optional, that's actually not true, because we are in the business of creating a healthy population. So it's actually mandatory. You have to do it, vaccinate your kids to be able to prevent pertussis. So the answer is false. Vaccination of preteens, teens and adults, including pregnant women with Tdap, is especially important for families with new infants. Then the next question is: pertussis is generally treated with antibiotics, which are used to control the symptoms and to prevent infected people from spreading the disease. True or false? So I'm talking about erythromycin, clarithromycin. These are antibiotics which are used to treat pertussis. So that's the treatment, antibiotics. So the answer is true. Pertussis is generally treated with antibiotics, which are used to control the symptoms and to prevent infected people from spreading the disease. Now the next one is worldwide there are an estimated 30 to 50 million cases of pertussis and about 3,000 deaths per year. Sometimes about 3,000 deaths per year. So that's actually the number. So people who get pertussis is actually the population is 30 to 50 million cases. And then also in terms of those who actually die from pertussis, that's 300,000 deaths, and that's every year. So the power question is pertussis is the next one is pertussis is caused by the bacterium Bordetella pertussis. So we talked about the bug that causes pertussis is Bordetella pertussis. So that's the answer. That's true. So now we have the Powerball question, your opportunity to be able to win a prize, and we have lots of interesting prizes from our sponsors, and you can be able to win a prize if you answer the Powerball question correctly. The information can be found in the material. So coughing fits due to pertussis infection can last for up to 10 weeks or more. True or false? Well, we talked about the 100-day cough, so that's 10 weeks. So I will let you answer that question and be able to win a prize. So right now, we're now going to the next session of the show, which is the residency interview question of the day. And we're still going through the interview season. I'm sure that you are on the interview trail or almost completed your interviews, and the rank order list quota has actually passed. So it's a very, very exciting time for everyone, getting to move to the next stage of your career, to be able to work towards finding the right fit for you in terms of residency, the right specialty, the right program, and make plans to be able to be part of graduate medical education, to be able to use your skill and your education to be able to learn, and also to be able to help to create a healthy population. So the question for today is how do you handle stress? And it's a very, very important question, because if you're an old graduate, or if you haven't been a resident before, then you could actually experience stress during your residency training, because it's a time for you to learn new stuff. I mean, even though you're smart, you went to medical school, and you actually are dedicated to medicine, but going through that learning period can also be very, very stressful. So you have to be able to integrate every factor in your life, and also to be able to learn quickly, and also work effectively and smarter, and smarter. So that's actually why we are answering this question today. So I mean, I actually have been under lots of stressful situations, and stress is actually caused by a combination of behavioral, genetic, and environmental factors. I'm leading to mental and physical illness. As a physician, I've been I'm used to stressful situations, and I've excelled in stressful situations by working harder, improving my efficiency, and also incorporating healthy habits to maintain optimal physical and mental fitness. So I have the answer here that and also incorporating pharmacotherapy. So the answer on the next slide is stress is a combination of environmental factors, genetic factors, and behavioral factors, resulting in physical and mental illness. As a physician, I am used to stressful situations, and I have excelled in stressful situations by working harder, improving my efficiency, and maintaining good mental and physical health, incorporating healthy habits and pharmacotherapy. So we are going to move to the next section of the show, which is the featured residency program of the day. There are lots of graduate medical medication programs out there, so you are able to interview, find out about them, and also find out the right fit for you, and be able to contribute towards healthcare reform, play your own part in healthcare reform. So today we'll talk about just one program, and I actually interviewed at the program, so I can be able to tell you a little bit about the program. I mean, most programs have the information on the website, and you can be able to read it, and also to get a little information about the program before you actually interviewed over there. And I interviewed that was March 2009, and I'm putting I'm a little word that's sharing of your interview encounters, especially about rankings against NRMP rules. So you can maybe share your interview experience, how you felt about the interviews, be able to know if you're a good fit for the program, and also to help those who are also going through the interview trail. But you don't tell anyone that they promise to rank you highly, or they give you a pre-match, because that's actually against NRMP rules. So we are not going to do that on this show. So going to the featured program of the day. The name of the program is University of Tennessee Internal Medicine Residency Program, Chattanooga, Memphis, Tennessee. So that's the program of the day. So the side of the program, they have 10 residents at each level of the 3-year program. So that's 30 residents total. Then the structure of the curriculum, I have a little chart here. I'm actually working on a curriculum review. As a resident, you have to for the 3 years, you have to be exposed to a wide variety of patient pathology. You have to be exposed to patients that you see in the emergency room, as a hospitalist, and also patients that you see in your clinic as a specialist or as a primary care physician. So that will expose you to the pace of the of the practice, and also the pathology. So that's actually what you have to incorporate into planning your schedule. So I have a little chat about the curriculum. The primary care core rotations are actually a major part of your training, and then you have the electives too, which actually help you to be able to learn how physicians practice in their clinics. So I have a list of all the primary care rotations. There's addiction medicine, there's adolescent medicine, there's allergy and immunology, there's ambulatory selective, there's also ambulatory rotations, there's also electives. So it's actually a combination of the electives and the primary care rotations. So on this slide, on the next slide, there are actually all the list of the electives, ranging from cardiology to chronic pain to adolescent medicine to gastroenterology to geriatrics to global medicine, public health to hematology and oncology, to hospital medicine to infectious disease. So that will actually help you to be able to decide exactly where you are going to fit into practice when you eventually graduate. And then the next slide has the primary care rotations. So you have everything ranging from office orthopedics, rheumatology, non-invasive cardiology, you have gynecology, and also GI procedures. You have internal medicine, general internal medicine, and that's where you learn a major part of the pathology. And then also you also have neurology and also psychiatry, and then also pulmonary medicine, radiology, research, sports medicine, women's health. So that actually gives you on a wide spectrum of the rotations available. And before you finish from the 3 years, you actually have a grasp of all the pathologies seen in medicine, and feel confident to be able to see those patients in your practice, and that's the aim of residency. So actually my research is gonna be what role does the electives and the core rotations play in getting the graduates ready for practice. So that will put in lots of factors like the ABFM results, the clinical rotations evaluations towards third year, and also the practicing physicians, what is the practice satisfaction from their practice. So and with that data, the program directors can be able to adjust the schedule, or just continue with the schedule, because the way it's structured already is quite optimal. You get to see a major pathology, a major part of the pathology during your core rotations, and then some part of your electives. So that's quite optimal for residents. So my interview experience at University of Tennessee, internal medicine program was actually very awesome. And the questions I was asked was tell me about yourself. So that's something that you hear from most interviews, because they're meeting you, they've seen your documents, they know all about you from what your preceptors have written, but then they want to meet you in person and be able to know you, because they work with you for the next 3 years. They are dedicated to teaching you, to be able to make sure that you actually use your knowledge, your skills to be able to graduate as a competent physician. So they want to talk to you and let you tell them about you, about you. So tell me about yourself. Well, for me, I would say I'm a 2007 graduate of American International School of Medicine with 10 years of clinical experience working as a certified nurse aide at various hospitals, long-term care facilities, nursing homes, with patients in their private homes, and from doing clinical rotations here in the United States, from 2 graduate medical education programs, Henry Ford Internal Medicine Residency Program, Detroit, Michigan, and from Springfield Family Medicine Residency Program, Springfield, Illinois. Working with the program directors, Dr. Kimberly Bekajino, an internist in Family Medicine Training Service at Henry Ford Internal Medicine Residency Program, and with the program director, Dr. Janet Albers, at Springfield Family Medicine Residency Program, and also from various externships and observerships from St. Elizabeth Family Medicine Residency Program. I'm working with Dr. Saida Zahidi, a program director emeritus certified in family medicine and pediatrics, and from Huntsville Family Medicine Residency Program, working with the program director, Dr. Mary Cristani, in Family Medicine Training Service, and also from Harris Fort Worth Methodist Hospital, working with Dr. Fidelis Unini in internal medicine. And then also from my preventive health care, where I've had the opportunity to go out to the community churches and also to charity works, and also offer free preventive care. And then also a master's in business administration from Davenport University, Grand Rapids, Michigan. Some research experience from University of Texas Southwestern Psychiatry Department. I'm working with Dr. Carol North and Della Downs, both awesome people. And also, I'm currently involved in preventive care and education and counseling of victims of sexual abuse and depression, which I haven't experienced personally, but motivated by patients I've seen in my practice. And I'm eager to contribute my part to healthcare reform. So that's how you answer that question. You have to integrate your career history, your journey through medicine, and also discuss your hobbies, your family. That's also what they also want to know too. But they want to know how ready you are in terms of starting residency, and also know about your career history. So that's how you answer that question. So the next question I was asked was, is your school, and most programs will ask you that, is your school on the California list of medical schools? So that's something that people need to know about. The Medical Board of California is a state government agency which licenses and disciplines physicians, surgeons, and certain allied healthcare professionals in California. And also some states apart from California also use these lists, and some schools are actually on the forbidden or the not to be licensed list. So you need to make sure to check there before you interview, and then be able to pick the right fit for you. The so my overall interview experience was wonderful. It was actually around Christmas, Thanksgiving. So some graduating residents had a party, and it was really awesome. They talked about the program. The residents shared their experience through the program, and how their clinical skills have improved, how their confidence has improved. And one of the residents actually talked extensively about how she has become more competent, more confident in handling cases. And she thanked the program director with tears in her eyes, which was actually very touching, because it showed that we are actually working to provide more physicians to contribute towards healthcare reform. So I would recommend that program to anyone. That's University of Tennessee Internal Medicine Residency Program. So the strength of the program, from my opinion, every program is equipped to teach residents, but they are supportive. Then also the structure of the curriculum too also makes them a strong program, because they make sure to cover all the topics, in primary care and also electives. And then also they also have the availability of procedures. That's something that you'll be doing in residency. Your endoscopies, your arthroscopies, your knee arthroscopies, joint arthroscopies. That's something you have to learn and be checked off. Normally you start off by supervision, and then after that you now I'm going to doing it yourself independently. And you actually have to learn about learn how to do it, become confident and competent, and also learn how to build for it, and also to follow up on it too, and also be able to do it in your own private practice. So that's something that you actually learn, and that's the strength of the program. So the program director is Dr. Lisa J. Stanton, MD, FACP. And she's also the medical director, University Medical Associates, UMA. And I interviewed with her and some other faculty. It was a very, very wonderful interview experience. And I thank the program director. I have that on the next two slides over here. The program coordinator, I apologize. That's Susan Andrews. Her email is sandrews8@uthsc.edu. And then on the previous slide, I have the contact information, the location, which is 956 Court Avenue, room H314, Memphis, Tennessee. The zip code is 38163. The phone number is 901-448-5814, and the fax is 901-448-7836. So that's the contact information. I have some tips for a successful interview. That's something that people always ask, how do I succeed in doing interviews? I mean, most programs want to be able to get to know you, to be able to see if you will be a good fit in their program, and also to be able to know what your career goals are. So you have to be able to explain that to them, to be able to tell them what you expect, or what you are aiming to in future practice, so they can be able to fulfill that. So just be yourself, tell them about your career goals, your hobbies, your family, and how eager you are to start, to contribute towards healthcare reform, how eager you are to work hard, and to meet up with expectations. So that's something that they want to know, about you. And then also, I have some tips here. I have on a picture here, how you should look. I mean, we as healthcare professionals, have to look professional, because we have to be able to portray the image of being competent and also being professional. So, I'm doing your interview season. You have to be able to portray that image in the way you dress and also in the way you conduct yourself. So I have a picture of a male applicant here, and trim haircut. You have to be clean shaven, and also have a warm smile, and also a feel of confidence, and also a formal dress. Suits, normally black or dark blue. And also have a firm handshake, because that indicates that you're ready for the encounter. You're confident, you are ready for to talk about you, and then also the correct body posture too. That's very, very important to be able to have a wonderful interview experience. For ladies, do not wear loud makeup, do not wear heavy jewelry, and also wear pants or skirts which are below the knee. That way you can be able to portray that confidence and also that competency to be able to learn in residency. So that's actually on the end of the presentation. We've talked about obesity and weight measurement, and also about pertussis, and we have the powerball questions, which I'm expecting people to send in their answers. For pertussis, the question is, coughing fits due to pertussis can last for 100 days or more, 10 weeks or more. So that's our power question for pertussis. And then for obesity, the power question is, is the risk for cardiovascular events increases progressively above blood pressure more than 115/75. True or false? So that's the Powerball question. Powerball question for obesity. You can be able to submit the answers to my email, which is listed on my website or in a form on my website. My email is drchiquito1@gmail.com. My Facebook ID, which is CHINYERE.A. If you want to get acknowledged and also to get people to work towards being part of the team of creating a healthy population, you can be able to post the answer on my Facebook wall. If you post the answer on my Facebook wall, you automatically get a prize, or my Twitter wall. So or if you like on my Twitter wall, and then that way you can be able to get the the answer to me. The drawing will be done on Saturday by 12 o'clock. We normally do our drawings on Saturdays by 12 o'clock, and we will also have some Zumba dancing, which is actually something that I do as a hobby. It's something that I actually learned last year. And also, it's a very, very, wonderful part of the Latin culture, and also, it's a good form of exercise, and also a way to, be able to spend time together as a family. On Saturdays by 12 o'clock, if you're maybe, hanging out with your family or with your friends, and you're watching this show, live, you can be able to dance along, lose a few pounds, and also have fun, and also be able to win a prize, a Powerball prize. So I encourage you to log in by 12 o'clock, and also send me your answers too. And then with that, I'm gonna round up. It's actually 8:51 a.m. And I want to wish everyone a happy day, even as you head to work, and also encourage you to log in tomorrow for the clinical case of the day, and also for physical examination session. And thanks once again.